Hello and welcome to the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley and I will be your host this evening. I am TMA Senior Manager of Education, Support, and Advocacy. Today we have the honor of speaking with Dr. Namita Goyal. Dr. Goyal, thank you for being here.
Happy to be here. Thank you for having me.
I'm going to read your biography real quick. Dr. Goyal is a professor of neurology at University of California, Irvine, and specializes in neuromuscular medicine. She serves as the director of the ALS Clinic, director of the Neuromuscular Medicine Fellowship Program, and co-director of the Neuromuscular Center at UC Irvine. Dr. Goyal has authored several neuromuscular articles and has given many national talks on neuromuscular diseases. In addition to evaluating and treating patients, she is a lead site investigator in several clinical trials involving neuromuscular diseases, with a special focus on ALS and myositis. She is also vice chair of TMA's Medical Advisory Board. Welcome and thank you for being here. If you have a question for Dr. Goyal, please type it in the Q&A box at the bottom of your screen. Before we start today's Q&A, Dr. Goyal will take a few minutes to share her work. Go ahead and share your screen.
Oh, great. Well, I want to thank everyone for allowing me to come and meet with you guys. I'm seeing in the participants that there's some familiar names that I even know. I'm just trying to make this a slideshow. Okay, can you see my slides okay?
We do.
But as many of you know, and those of you that don't know me, I'm very passionate about myositis. It's a topic that's been near and dear to my heart. I've been in clinical practice for 16 years. I started my career at the Harvard Hospital in Boston at Mass General. And early on in my career, I noticed that there was a huge unmet need for better therapies, for better diagnostic approaches, and just all around better management for our myositis patients. And I've really taken it upon myself in this past 16 years to meet with my patients, to understand how they are. And I just wanted to share with you about 3 different bullet point topics that we've been working on over these years, specifically in inclusion body myositis. And so as you all know, with IBM, it is a slowly progressive muscle condition that's characterized by atrophy and muscle weakness that affects predominantly the finger flexors and the quadriceps muscles. And over time, patients can have significant gait difficulty, motor disabilities, swallowing difficulties, and leading to poor quality of life. And one of the challenges in developing clinical drugs for patients with IBM is that the cause of the disease is still not well understood. There's still this ongoing debate if it's a degenerative disorder or if it's autoimmune in nature. But I'm happy to report that really in the past 5-10 years, we've had a better understanding of what might be causing the disease. And one of these findings, as many of you may know, is the NT5C1A antibody that was discovered in inclusion body myositis. It has been reported to have varying sensitivity, but quite high specificity. And so we have used this as a diagnostic biomarker. Our group here at UC Irvine was the first to report why some patients may have the autoantibody and why others don't. So we did a study looking at our patients, and we did a number of clinical evaluations along with antibody testing. And we enrolled about 25 patients. This was when the first autoantibody was discovered back in 2013. And we found that 72% of our patients are positive for the autoantibody. But we were curious about why some IBM patients have the autoantibody and others don't. And what we found in our study was that patients with the autoantibody had more swallowing difficulty, more difficulty ambulating, and could even have lower breathing numbers. We published these results back in 2016, and basically characterizing that patients with the autoantibody might have a more severe phenotype. And then interestingly, because our study was small, 25 patients, a European group the year after said Goyal and colleagues might be onto something. They studied 300 patients with IBM, and they found similar findings that patients with the autoantibody may have more severe motor deficits, more swallowing difficulty, more use of a cane or a walker, and even higher mortality risk, which was an interesting new finding. However, I'll tell you that then we collectively did a much larger study. This was in collaboration with our group, Dr. Weil's group from Washington University, and Dr. Wong's group from Seattle. And we studied, again, 250 patients. This was a retrospective study, meaning we didn't study all the motor assessments that we had done in the prior study. But this new study found that maybe there is not a difference between the patients that have the autoantibody and don't. There was no swallowing, no difference in swallowing difficulties between the two groups, and there was no difference in survival. So long story short, we have conflicting reports now. And that has really led us all to sort of scratch our heads and try to understand, what does this autoantibody really mean in IBM? And how can we really measure disease progression? What is the actual disease progression? And this has led to my second bullet point, which is Dr. Mozaffar and I have planned and started this large natural history study in IBM. It's called Inspire IBM. And what's great is it's an NIH funded study, which means we finally got the NIH interested in IBM, and hopefully this interest will garner future drug development. But one of the big barriers to doing clinical trials in IBM is we haven't truly characterized how the disease progresses. And this is what we plan to do with the natural history study. We're trying to study, how does the disease progress? What do the antibodies, as well as all the different T cell populations, actually mean, and if it influences disease progression and behavior? And so we actually used patient input while we were planning the study. And the study has now started since late last year. It's a 2-year study, and there's 5 visits total. And any of the IBM patients that are out there, if you're eligible, we would certainly love your help in completing the study. So a lot of the assessments we're doing in this study are very similar to routine clinical exams. There is an optional muscle biopsy, and then there's a number of questionnaires. But mainly, we're looking for IBM patients that have had IBM for 10 years or less. So unfortunately, some of you that are out there that have had IBM for 10 years or greater, that wouldn't fit the inclusion criteria. But it's going to be a very helpful study in characterizing IBM definitively. And we actually have several sites in the US. So if you're close to any one of these centers, please consider, and you've had IBM for 10 years or less, please consider participating in the study. I think it's a fairly easy study. It's 2 visits in a year for a total of 5 visits. And here on the left, I've included the number of sites or universities that are involved. And if you are interested, our project manager's name is Marie Wenzel. This is her email address and phone number. And if you want to take a screenshot, or if you don't get it, I'm happy to send it to you later. And then the last bullet point I wanted to share was, what we are doing to further understand what causes IBM. So I'm excited to report that there are some more recent advancements in looking at what's causing IBM. And one of these has initially been reported by Dr. Greenberg from Brigham and Women's in Boston. He reported in 2019 that we all know, I'm going to try to simplify this a little bit, but we all know in IBM there's inflammation. And many of the inflammatory cells are T cells. What we have recently learned is that these T cells, there's different populations of T cells, but the T cells that seem to be disease causing in IBM are these very highly differentiated cytotoxic T cells that seem to express a marker called KLRG1. So on the surface of these T cells, Dr. Greenberg found that there's a marker called KLRG1. It's actually found in IBM muscle as well as in blood. And we believe that it's potentially what is causing disease in IBM. So we did a study after these findings were reported. We did a study with Dr. Greenberg and our immunologist here at UC Irvine, and we enrolled 51 patients. And we found very similar findings, that the KLRG1 seems to be most expressed on the CD8 T cells, and this is sort of a population of T cells that you're seeing on the right side. And the KLRG1 seems to be expressed greatest in the most differentiated T cells. What we also studied was that, and found, is that these T cells seem to be present with longer disease duration. You see this greater differentiation of T cells that express KLRG1. And interestingly, when we looked at disease severity based on the IBM functional rating score, we saw that these T cells are present irrespective of how severe the disease is. So in milder forms, as well as in the most severe forms. And so for those of you interested, we did publish these results in the Neurology Journal just this year, a few months ago. And these findings, as well as Dr. Greenberg's original findings, have garnered a lot of attention. And I'm happy to report that there is a new drug in development. This is by the company Abcuro, and the drug's name is ABC008. It's basically targeting KLRG1 and trying to deplete these highly differentiated cytotoxic T cells that are thought to be disease-causing in IBM. So the phase 1 studies are currently underway in Australia, and they're expected to be done by end of year. And the phase 2 studies are being planned for in the US by the fall or winter of 2022. And that's sort of highlighting some of the work that we have been doing. So I'm gonna stop share my screen so that I'm happy to answer questions. I know I talked about IBM today, and but I do see other myositis patients. So if there are other myositis patients with questions, I'm happy to answer them as well.
All right, well, let's take a look in our Q&A and see what we have for you, Dr. Goyal.
Oh, great.
What is the youngest patient you have diagnosed with IBM?
Oh, that's a great question. So in the IBM diagnostic criteria, the age is set as 45 or above. Having said that, I have had patients in their 30s that we've diagnosed with IBM, and many of my colleagues can report that as well.
Thank you. What determines how long someone is on prednisone? What exactly is the doctor looking at?
So I'm assuming prednisone, we're asking about dermatomyositis or polymyositis or antisynthetase syndrome. For inclusion body myositis, we typically don't use immune suppressants, and that's because we've learned over the years that unfortunately steroids like prednisone and other immune suppressants like methotrexate or azathioprine aren't effective in slowing down disease progression. But in other myositis subtypes like dermatomyositis or polymyositis, what we're typically looking for is can we see improvement in muscle strength? That's a very helpful marker. Some clinicians will follow CK levels or muscle enzyme levels. Those typically will drop after starting prednisone, but they're not as reflective of an improvement in therapy as much as muscle strength is.
Okay. Is it true that myositis can elevate ALT and AST liver enzyme counts? What is the reasoning for this? And if the levels are raised, then does it necessarily mean there are issues with the liver? How can we be sure there's nothing wrong with our liver?
That's also a great question, and unfortunately a misconception by many primary care doctors or non-myositis specialists. So I want to explain this, the background on this. So in myositis, we typically look for CK or creatine kinase elevations, and we always think of that as muscle specific. However, AST and ALT generally are characterized as liver enzymes, but that's actually false. They are also present in our muscle. And so anyone with myositis that has CK elevations will also often have AST, ALT elevations. Now, a primary care doctor, when they just do routine blood tests and they don't check a CK, in the routine blood tests, AST and ALT are always present in that panel. And so they think if they're elevated, a primary care doctor might think a patient has a liver problem, and all of a sudden a patient is getting a bunch of liver workup. The way to really troubleshoot that is by checking a CK level and also checking a GGT level. Now, the GGT enzyme is actually liver specific and not present in the muscle. So typically in myositis, AST, ALT, CK will be elevated, but GGT will not be elevated because that's liver specific. I hope that makes sense.
Have you seen through your practice myositis patients that do not have pain, but only have tightness and soreness?
Yeah, absolutely. We see all varying of symptoms. In general, it used to be thought previously that myositis patients don't have pain, but they may have more what we call myalgias, which is really muscle soreness or tightness. But we've also learned that you can see pain. And I think it just varies depending on the patient, depending on the condition, but it's not specific to one subtype or another. I think I saw another question about how long do you determine for someone to be getting IVIG treatments? I think that's similar to the prednisone treatment question, that we use IVIG in dermatomyositis, polymyositis, antisynthetase syndrome, necrotizing myopathy. Unfortunately, again, has not really shown to be robustly effective in IBM, so we don't use it in IBM. But again, one of the primary features we look for in myositis treatment regimens is, do patients have an improvement in their muscle strength? And for me, a period of around 3 to 6 months is helpful for prednisone or IVIG to suggest if they're improving or not. If not, that's the time I like to reevaluate, make sure the diagnosis is correct, as well as make sure that if that agent isn't working, considering another agent.
I'd like to remind everyone, if you have a question, please put it in the Q&A and not in the chat. The Q&A is where we are monitoring our questions for the webinar. Thank you. Let's turn to nutrition. This is a really cute question. Does every myositis patient have to follow an anti-inflammatory diet? Have you seen people go into remission and be able to eat dairy and carbs? I say cute just because somebody wants some cake, you know, and I get it.
So have I seen people go into remission and be able to eat dairy and carbs? You know, I think this anti-inflammatory diet periodically comes back over time. And I don't think we really have a clear answer in terms of which exact diet regimen we need to follow. What I tell my patients is a well-balanced diet is actually very important. I think high protein is helpful for patients with a lot of muscle atrophy. But I also am not a believer in cutting. I like my carbs, so I appreciate your cute answer question, because I definitely like to eat everything, but I think eating it in moderation is very helpful. And I tell my patients that if they are having muscle loss, muscle atrophy, to concentrate on the proteins. If it's you know, meats, red meat, fish, and beans, legumes, they're all lentils, they're all a good source of protein.
What would you say is the amount of protein that they should consume each day?
You know, I don't really, again, go by a fixed amount, but because everyone has a different body mass index, different height, different weight. So what I tell my patients is, if you really want to get on a more strict regimen, it is helpful to see a nutritionist, because they can actually map out amounts, calories that's appropriate for your height and weight.
Do you have opinion on any supplements that are good for an IBM patient?
Yeah, you know, I think there is a lot of buzz about creatine and coenzyme Q10. I haven't seen any major contraindications. We don't really have a set regimen for IBM patients, but interestingly, in ALS, there is this website called ALSuntangled.com, which actually reviews a number of supplements in a more systematic way. And I actually use it for almost all my patients that are interested in supplements, because it gives them, you know, sort of a more scientific, systematic review of which supplement may be helpful or harmful. And it's got now probably, I don't know, well over 30, 40 supplements on the website.
And what is that website again?
It's called ALSuntangled.com. I can put it in the Q&A if that would be helpful, or in the chat.
Thank you.
It is a helpful website, I think, for anyone that wants to sort of understand what supplements may help. So I just put it in the in the chat.
Okay. Is there any research or knowledge relating to ligaments, tendons, regarding inflammation, weakness, and/or deterioration in types of myositis, and any treatments for these conditions?
With respect to ligaments and tendons, you know, as you guys know, our bones have a ligament and tendon that connect to the muscle. So we haven't really studied ligaments and tendons specifically in myositis patients, but what we do know is that, if the muscle is severely damaged, ligaments and tendons can be more susceptible. But I would say that we, by concentrating on improving muscle health and muscle strength, we indirectly help improve ligaments and tendons surrounding that. And exercise is also a very helpful feature in myositis that I think is underappreciated. And we probably don't counsel our patients enough about doing some form of exercise, which definitely can help strengthen our ligaments and tendons.
With exercise, is it possible to rebuild muscle, or are you simply slowing progression?
I think it depends on the type of myositis subtype. In what we characterize as autoimmune myositis, which are the dermatomyositis, necrotizing myopathy, polymyositis, the ones that we believe are responsive to immunotherapy and immunosuppressants, we believe that you can actually rebuild muscle too. With a good treatment regimen, meaning steroids and immune therapy, as well as exercise. I think they actually go hand in hand, and there are published studies suggesting that patients that do both can actually rebuild muscle. We do know muscles can regenerate. In IBM, unfortunately, I think it's a lot more complicated. We do have studies that suggest that some form of exercise is better in IBM than no exercise at all. But I would say in IBM, I think right now we aim for trying to slow progression with exercise rather than being able to say we can actually grow muscle back.
Is it possible to exercise too much and then cause damage?
Yeah, that's a great question. I always give my patients the motto of no pain, no gain is not the motto. So we're always taught, when we're young and we're in, gym class, you got to exercise till you're having muscle pain or burn. But in myositis, we don't want that because there is a point where you can cause muscle breakdown or acceleration of muscle breakdown by doing heavy weightlifting or exercising to the point of exhaustion. So I tell my patients exercising where it feels good is great. If you're exercising to the point where the next day you can't get out of bed because you're way too sore or you're extremely exhausted, that's a sign that your body's telling you it's too much. And of course, you always want to slowly build up to any exercise regimen you're doing.
Okay. Any thoughts on how often people can seroconvert from negative NT5C1A to positive?
That's a great question. I see that's by Jim. That is a great question that I have actually been interested in from a research standpoint. And it's interesting because in the study that I presented with Dr. Weil's group and our group of 249 patients, we actually had one patient who seroconverted from negative to positive, and we had another patient that converted from positive to negative. There were only two in that group of 249, I believe. So we don't really know why or how that happened. It was actually the same laboratory that it was being tested at. So long story short, because of these findings in our natural history study, where we're prospectively measuring antibodies and disease progression, we're going to be taking a deeper look if patients are seroconverting. I
Go
see
ahead.
the question about the natural history study, and they're based in Chicago, and do they need to travel to St. Louis? Right now, unfortunately, I think that is the closest site. However, very recently, Dr. Mozafar told me he may be entertaining if he can open a site in Chicago. So that is under works, but in the interim, I believe St. Louis is the closest site to Chicago.
Since most IBM patients believe they have had the disease for a number of years before diagnosis, how do you decide when onset is?
That's great. Jim's asking all the million-dollar questions. That's a really important point. And even for the natural history study, as you may know, many of us IBM experts are involved in this study, and that's been significant debate, even in how we've been enrolling patients, because as you saw, that patients had to have symptoms for 10 years or less. But I think what we've generally come to the consensus is we really try to press the patient and asking, because I think a lot of IBM patients realize in retrospect, symptoms may have started earlier or by years before when they started actually being evaluated. What we ask patients is when they think they really developed muscle weakness that required medical attention or something just really changed in their body. But I know that's still a great area in trying to pin a patient down and decide exact disease onset. But we look for weakness as a sign. Weakness, falls, something that changed in their walking.
Can you talk about polymyositis shifting or morphing into IBM? Was it IBM all along, or did it really start as PM? We get this question a lot in our support groups.
Yeah, we get this question a lot, and it's something me and my colleagues have thought about a lot, do PM patients actually end up having IBM? It's an unanswered question is the short answer. But what we have realized, it's interesting because if you look back at the history of myositis, back in 1881, it was polymyositis that was the first myositis ever described. And it actually was composed as a single entity of myositis. The category of myositis was basically polymyositis. It took about 4 years for clinicians to realize that there's a subtype called dermatomyositis, and it took about almost another 100 years before IBM was discovered. Now, fast forwarding to year 2022, most IBM or myositis experts, I should say, realize that polymyositis is almost a rare entity, and some even question if it exists or not. Many of our IBM patients, in fact, I think I read in the literature once that almost 40% of IBM patients are initially misdiagnosed as polymyositis. So is it because all the clinical features aren't there? Is it because what we thought was polymyositis actually evolves into IBM? They're unanswered questions, but our suspicion is that most polymyositis patients end up being IBM patients if they're over the age of 45, and if they've not had a response to immune therapy, we definitely become suspicious about IBM.
Are there ways to measure KLRG1 from blood samples versus muscle biopsy?
Yeah, so in our study, we measured them only from blood samples. Dr. Greenberg in 2019 showed that you can measure them from blood and muscle biopsies. they are not commercially available. So right now it's only being done on a research basis. But in our natural history study that we're doing, we are going to be analyzing KLRG1 also.
Okay.
I see there's a question on rationale to taking CoQ10 with IBM, DM, or PM. Coenzyme Q10 is one of those supplements that I think is being looked at in many conditions, many muscle nerve conditions. So it's not really specific to one subtype, but we do think that it is a beneficial supplement. And so, you know, what we also know is that there's no significant harm in taking it. While I wouldn't say it's the cure for any of the myositis subtypes, we do think it's a beneficial supplement. The next question I see is, do we see loss of grip or hand strength with dermatomyositis? Generally, we think about dermatomyositis as being a muscle disease that affects our shoulder girdle muscles and our hip girdle muscles. However, when patients will have sort of more severe involvement or longer standing involvement, really over time, all muscles can be involved. So it wouldn't surprise me if I saw grip or hand strength weakness in someone with severe dermatomyositis or just long-standing dermatomyositis. And then again, there's the skin component in dermatomyositis that affects our hand joints and our hands specifically. So again, I'm not surprised when there's hand grip strength weakness in dermatomyositis. I see a question about exercise. Can it increase the size of muscle in IBM, but not strength? Why? And I wonder, can exercise increase size of muscle, but not strength? You know, I think it's an interesting question, and it reminds me of the bimagrumab study in inclusion body myositis. So for those of you that don't know, there was a study done probably 7, 8 years ago in inclusion body myositis with bimagrumab. Bimagrumab is a myostatin inhibitor. And when you inhibit myostatin, you can actually grow muscle back. So we thought this was going to be a remarkable and a very exciting study in IBM, especially IBM, because unlike some of the other subtypes, we see profound muscle atrophy in IBM. And what we learned from that study is that bimagrumab did indeed help grow back muscle, but unfortunately, it didn't make the muscle stronger. And I don't think there's still a good understanding of why. I really think it probably has to do with a lot more understanding of the protein and the mechanisms that are involved in IBM. And it's not as simple, but similarly, I think exercise in IBM can help at least stabilize some of the muscle loss, but I think it's really challenging in IBM to significantly grow back muscle with exercise alone. I do think bimagrumab was a helpful agent, and I'm hopeful that when we can find another drug, I did see a question later on about combination therapies in IBM, and we definitely think there's going to be a role for combination therapies, just like our patients with cancer, when they get chemotherapy, it's not just one drug, but it's several drugs. We're wondering in IBM, if we're going to use a drug like bimagrumab that can help grow muscle, and then we're going to need another drug to help make that muscle contraction stronger. My doctor wants to take me off prednisone. It seems like it's the only thing working for me. Is there anything that works like prednisone but without the side effects? That's a great question for myositis subtypes that are responsive to prednisone. So I'm assuming when this patient is asking about prednisone, we expect that prednisone helps improve muscle strength. Now, if it's not improving muscle strength, that could be a reason to take someone off prednisone. But if it is improving muscle strength, I actually don't like the long-term side effects of prednisone. We think of it as a great drug, but what I call an ugly drug, and an ugly drug because there's a whole panel of side effects that come with prednisone, like weight gain, high blood pressure, risk of diabetes, risk of glaucoma or increased pressure in the eyes. And so this is when we turn to other agents that we call steroid-sparing agents, like azathioprine or methotrexate, are two very common agents in myositis that we use because it spares a patient from the side effects of prednisone. So oftentimes, if I'm trying to get someone off prednisone, I'll start azathioprine or methotrexate, and then I hope to wean the prednisone and keep them on something like azathioprine or methotrexate because it generally doesn't have the long-term prednisone side effects. I see the next question says, does it make sense to track CK levels in IBM patients since there's nothing to do to mitigate it? It appears that when my CK levels go up, I experience more disease progression. That's a great question that is commonly asked by many of my IBM patients. Unfortunately, what we've learned and what we've seen is that CK levels seem to be highest early on in the disease course, when the disease is new to a patient, when they're sort of continuing to progress. But irrespective of ever being on prednisone or immune therapy or not, what we also see is that when the disease is sort of long-standing or when patients develop significant muscle atrophy, the CK levels naturally start trending down. For us as clinicians, I'm not one to treat lab values as much as treating the patient. And so for me, what's more telling is how a patient is doing with regards to their muscle strength. When you go into your neurologist or rheumatologist's office, they'll often do an exam where they're checking muscle strength. That for me is much more insightful in seeing if scores have changed rather than CK levels have changed. I don't get married to the CK level as much because at some point the CKs burn out when the disease has progressed so much, but I can see that a patient's still progressing, but the CK level may not reflect that. So following that question, I see someone wrote, I'm 71 with IBM and my CK level is now normal. And I think that is reflective of what I was just talking about. That's a perfect example where as the condition may have progressed, the CK levels normalize because there is so much muscle atrophy that it can't really measure muscle weakness at that point. But following with your neurologist is really important to see if your muscle scores are changing, if your breathing numbers are declining, if your swallowing has changed. I think that's much more important than monitoring CK levels at that point. How do you diagnose different forms of myositis? That's a great question. Unfortunately, we have a number of great diagnostic tools to help us decide what subtype you have. It traditionally and classically used to be a muscle biopsy. A muscle biopsy based on a pattern could tell us if it was dermatomyositis, antisynthetase, or IBM, and that still holds true. But luckily and fortunately now we have blood tests that can also help us with subtypes. So for those of you that don't have or haven't had myositis antibody testing, it's a simple blood test that can be done by any neurologist or rheumatologist. It's commercially available. There are many labs that do it. And based on the autoantibody, you can also determine which subtype you have. The panels are very broad. And so if you just ask for, can I get tested for a myositis panel? They often include many of the autoantibodies that will tell you which subtype you have. Rachel, feel free to interrupt me if I am not answering some of the questions that you see, but I'm just going down the Q&A list that I see.
No, you're doing fine.
Okay, great. I see someone wrote they're prescribed azathioprine. Can I explain details about it? Azathioprine is a very helpful agent that we use in myositis. It's been shown over and over again to be beneficial in dermatomyositis and antisynthetase syndrome. It's what we call a steroid sparing agent. So oftentimes if you've responded well to prednisone, your clinician will start azathioprine. It's usually a twice a day dosing, with the most common side effects sometimes being GI upset, but many of my patients tolerate azathioprine quite well. And what it allows clinicians and patients to do is it allows you to get down or decrease the prednisone. So reducing some of the prednisone's side effects while maintaining the benefits of improving muscle strength. I see a patient asked about leg spasms. Is that a common feature? We can see leg spasms, muscle cramps in all myositis subtypes. Unfortunately, it's an annoying feature. I tell patients to stay well hydrated. There's anecdotal experiences of tonic water even helping leg spasms. So tonic water has some quinine, and quinine's been taken off the market as a pill because it caused heart irregularity or arrhythmias. But tonic water does have a little bit of quinine in it. And some of my patients tell me it is very helpful for their leg spasms. Other patients will say it's not really helpful at all, but it's something that you can try. I think I've answered some of these questions. I'm gonna scroll down. Someone asked about 20 milligrams of prednisone. If that is, I take it for once a day for 2 weeks with no improvement. Should I have stayed on it longer or a different dose? That's a great question. 20 milligrams of prednisone can be effective, but I think it really depends on how severe muscle weakness is. If someone has very severe muscle weakness, sometimes higher doses are required, and for longer periods of time. 2 weeks can be a short amount of time to know if it was helpful or not. Oftentimes I'll try 1 to 3 months even to know if muscle strength improved. So it might be something worth discussing with your doctor. Again, it depends on the subtype of myositis that you have.
Dr. Goyle, let me interject a few of the questions that came
Okay,
in
great.
from our email submissions.
Okay.
I've got one. I've read it's believed that MHC genes on chromosome 6 are associated with various autoimmune diseases. Has research been done to see which specific genes are associated with IBM? If so, where have the results been published? And if not, do you think there would be benefit to look for the possible genetic link?
Oh, that's a great question. So genetics in IBM is being looked at. There's actually IBM Genetics Consortium that has been held and with work sort of ongoing. But I don't think the answer has been definitively made about exactly which gene. There is some work on HLA, DRB that's been published in genetics and IBM. And if you went on to Google Scholar or PubMed and just typed in genetics and IBM, I'm pretty sure you could come across 2 or 3 of these articles. But there is, just to answer briefly, there is work that is ongoing, and we are looking at certain risk factors. If you can have some of these genes that could potentially be a trigger or a risk factor down the road into leading to IBM.
My question is regarding the role of bacteria or even a virus may play in being the trigger or one of the causes of IBM or other myositis. I've seen an article that indicates that a course of antibiotics could help with reducing inflammation. What is your opinion regarding the role that antibiotics may play in slowing progression?
That's a great question. And to go to your first part of the question, there is a lot of work that is being done in some of the viruses. We have seen linkages between the HIV virus and IBM, not saying that IBM patients have HIV, but what I'm saying is that some HIV patients, interestingly, have an increased risk of developing IBM. Similarly, we've seen hepatitis C virus as having a linkage between IBM. So I think these are important questions that are still being explored. Having said that, I think it's really important not to take an antibiotic off label until further research is being done. You certainly don't want to jump the gun and take an antibiotic in IBM. And I'll give you an example of this. There was some prelim work in ALS with minocycline, which was an antibiotic that was on the market for treating acne even. And so there was some early work that showed that minocycline could be helpful in slowing down ALS. So a large clinical trial was done, but patients were thinking, well, why should I do the clinical trial when minocycline's already on the market and I could just go to my primary care doctor and get minocycline? And that was unfortunately what was happening, was that patients got very excited and said, I'm just going to start it because what's the harm? I have no treatment. But what they learned in the clinical trial, they actually had to stop the clinical trial during the interim analysis because they learned that patients that were on minocycline actually had worse progression than patients that were on placebo and not getting drug. So the antibiotic question is a great one, but I think further work needs to be done, and you shouldn't take an antibiotic in the interim until we get more conclusive results.
Thank you. You can go back to the Q&A box.
I see a question on blood flow restriction therapy, and I think that's a great question because I know many of my IBM patients are looking into blood flow restriction therapy as a potential therapy. I think what I would say is that studies are ongoing. We don't have definitive conclusive results saying that it's beneficial. Having said that, I think it's a very interesting idea where they're trying to sort of target the immune system and regulate the immune system by doing this blood flow restriction. And I think we're going to learn more about it. I don't see any significant harm in doing it. So my patients that are doing it, I'm curious about it just as you guys are, and I'm hopeful we'll get more definitive answers in the next year or so. Let's see, MHC. I have DM and I exercise 3 times a week. I have increased my strength and endurance. However, I'm having difficulty going upstairs. Will this continue, or will more specific exercises help with this? That's a great question. And in my opinion, when I see my dermatomyositis patients, I don't feel like I'm done until I have treated them completely. And I'm happy to report to you guys that I have several dermatomyositis patients under my care that don't even realize they have weakness anymore, or don't even think they do. And I don't think they do either, because their dermatomyositis is so well treated. And I think it goes back to the point of getting on the best immunotherapy regimen in addition to the exercise. But I don't think exercise alone can help improve the strength. I think you do need to be on a good regimen. And so if you're still having difficulty going up the stairs, and you've been on immunotherapy for a long time, it may be worthwhile asking your clinician, are you on the right regimen? Are there other agents out there that can be better suited for you? And lastly, I'll throw in a pitch for clinical trials. I know I've talked a lot about IBM, but I do clinical trials in dermatomyositis too. And there are a number of clinical trials that are ongoing. I think the TMA website is actually a great website for patients. I'm so thankful for the work that TMA does, because as a clinician taking care of my myositis patients, I've really used it as a resource for my own patients to tell them, hey, look, on the website, they can tell you about clinical trials that are going on, support groups, learning from other patients has been very helpful for me too. And I find my patients find it helpful also. Rachel,
Dr. Goyal, do you have any remaining advice or any words of hope or encouragement for the patients out there dealing with myositis?
Yeah, no, thank you for that. I have tons of words of hope and tons of encouragement. I think we are entering a completely different era where we are finding better treatments. Prednisone should not be the only treatment option for patients with other subtypes. And I'm gonna again throw in a pitch for TMA, because I have been so fortunate to be a part of the medical advisory board. I will tell you, I go to tons of meetings, but the meeting that happens in September with TMA is one of my most favorite meetings, because patients and experts get to engage. I learn from the patients that come, as well as I think patients learn tremendously from that meeting. So thank you, TMA, for hosting that. But I think there's a lot of cutting edge therapies that are happening these days, both in dermatomyositis, necrotizing myopathy, but also in IBM. I foresee a lot of new therapies down the pipeline. So
well, thank you so much. We are so excited to have you. This has been a wonderful session. We had over 55 questions in the Q&A box, and we had others submitted by email. And if we didn't get to your question, it will be submitted automatically to the next Ask the Doc, which will be July 21st from 6 p.m. to 7 p.m. Eastern Time, when we will meet with rheumatologist Dr. Florian Ernst. And also, Dr. Goyal was so nice to bring it up, and I will as well. We invite you to participate in our 2022 International Annual Patient Conference, which will be held in person in Orlando in September. And we will also have virtual option for those of you who are no longer able to travel, so you will not miss out. You may register for the event on the website, myositis.org. Thank you, Dr. Goyal. It was great to have you. And for TMA, I'm Rachel Bromley. Good night.
Thank you. My pleasure.